If you have any questions regarding previous topics or cases that you have, you can just go ahead and ask them anytime. So just to wake us up, we're just gonna look at this from the superficial. So looking at the visual cues and what we can see from this patient. Okay. So anong nakikita nyo rito? This is the closed mouth. This is the physiologic rest position, the smiling, and of course the profile. Yung tenga niya yata nilagyan ng mighty band dito eh, kaya ano, hindi na crop yan ha, talagang ganyan. Low angle. Okay. I think your visual cue, did you say low angle? Okay, I think the visual cue that you're looking at is this one. Kasi yung posterior niya medyo pababa. Parang naka-curve of spine. In fact, yung curve of spine niya is really big. You know, samaan ng curve of spine niya. But we have to, when we're looking at these photos, we have to look beyond the dental. Although that's legit. Okay, that's legit. That's something you must observe. So what are the other things that we look at in terms of the angle of the patient? Mandibular plane angle, which isn't so obvious, but somehow we have a cue, so it comes from there and it goes over here. Lower facial height, is it longer than the middle facial height? So the most valid point that we can talk about from this standpoint is that we're looking at the lower facial height in reference to the middle facial height. So if it's higher, then there is a tendency that this patient, there is a possibility that this patient is a high angle case. Now, both of us are not proven. Okay, both of us are not proven right until we check the Ceph. Okay, but these are visual cues that we must look at that would help us in terms of looking at the patient and how we can think of things to improve the face of the patient. Okay, so what do you observe here is physiologic rest position? Incompetent lips, yeah. Okay, so so we do have incompetent lips, which means they don't meet. But the question is this incompetence normal? Or is it something out of the normal? What do we mean by incompetent normal? Incompetent normal would be the upper lip might be thin. And if the upper lip is thin, it's short. If it's short, and we usually see this in Caucasians and medyo mga mestiza, that could be a normal. You can't do anything about that kind of situation where the upper lip is short. But in this situation where you see that the upper lip is not that short, it's actually long, so we can assess that this is actually an abnormal incompetence. So physiology is definitely hampered. So by visual of that incompetence, what do you see with the teeth? In relation to the upper lip. Is there too much show? So I would say that there's too much show of the upper teeth. In fact, when he smiles, it's high gingival, right? Considered high gingival, but it is actually aesthetic. So the question is, with the objective that I have to make the lips competent. Why? So that there's going to be physiologic moistening of the lips. Because every time your lips close, they must moisten each other. Hindi pwede na nagda-dry. So we do see those patients na they usually have the habit of like binabalatan nila yung lips nila, or their lips are naturally dry, or some are even everted na yung moist region is already out, further out. And this guy isn't like that bad, but sorry, his lips are also dry. So that means this position isn't really normal. He showed me in this picture, but sometimes as a diagnostic, we usually deem this patient, okay, this is normal, when actually it really isn't. Okay, so that's the importance of your physiologic rest position. And let's look at the difference also. So one way to correct this is by auto-rotation. And by auto-rotation of your mandible, we can allow the jaw to come a little bit more forward and a little bit more upward. Look at the profile. That would benefit the patient a little bit more forward and a little bit more upward, and that will help your lips to meet accordingly. And by thinking about the aesthetics of the upper anterior teeth, do you think this patient needs intrusion of the upper anterior teeth? Yes, because there's actually too much show of that upper teeth. Okay, so what do we do about it? Intrusion by TADS? Not too much. I mean, we don't want to hide it, but we want to conceal it a little bit more. Siguro mga intrude it for about 2-3 millimeters, no, at least 3 millimeters, and bring it in. And that would benefit. Okay, so let's go here sa intraoral. If I intrude this anterior teeth to this level, like halfway, right? And I go halfway, I'm still gonna have an exposure of teeth, right? And if I still have an exposure of teeth, even at halfway, then let me visualize, if my occlusal plane is at this level, then my posterior should always also be, and look at the level of the second molar. Halfway. And this is why I don't usually band my second molars. Not usually. I mean, yeah, majority of the time I don't band my second molars because they're my guide. Okay, unless they're really out. Before finishing, I usually band them all, bond them all if I need to. So if we're gonna think, how bad did this case get? Just by looking at this mouth and looking for visual cues in terms of how on earth did this happen? Well, we can think about, diba? Nawala yung lower 6, super erupted upper 6. Look at this. Your posteriors na nakahiga are usually deemed na, oh no, it's it dumped into that space. But actually, what may have happened here, if you remember, this is my occlusal plane, this is my posterior, my lower, this is my mandible, and after the upper super erupted, look at my molar. It now seems like it's lying down. It's not really lying down, it's actually rotated downward. So what does that mean? If I intrude the upper, okay, alright, so let me just add the anterior teeth. So what happened to the anterior teeth because of the super eruption of the upper, it compensated. So now it's this one that looks bad. So since that compensated, now when you intrude again the upper, problem is in the front. So intrusion of the upper, intrusion of the lower as well, and that one would restore your occlusal plane. So coming from your visual cue a while ago where you said that the occlusal plane looks low over here, it actually is. And we have to intrude that, allow the mandible to auto-rotate. We can correct that lip competence. We could also correct the how much anterior teeth are actually showing. And we're going to be able to flatten this occlusal plane, right? So as this mandible rotates upward and forward, this canine would also come a little bit forward, but it's not going to go into full class 1. Okay? So, and that would somehow correct your whole case. Now, if you observe in this picture here, look at the quality and quantity of the bone in the maxilla. It's rich. Compared to the lower, it's not. So that means that if I extract in the upper, right here, isa, then retract all these teeth over here, I can retract and also intrude a little bit, but then how much bone is it going to be in terms of the ratio with the teeth? It's going to be a little too much in terms of the upper. So that's a trouble in terms of what we are supposed to do in the X of the upper. Profile is actually flared for the upper anterior, but for the posterior, for the buccal corridors, we do have a lot of allowance that we can use in terms of the intrusion. So biomechanics, when we're going to intrude this whole segment over here in the anterior, up to the 6s, it's okay to place a TAD, okay, on the buccal only, maybe around 4, and because it's coming from the buccal, if say for example this is the tooth, right, and this is the buccal side, and if I am the TAD and I'm gonna pull this in, I'm not only gonna pull this in like that way. What's gonna happen to this one? It's also gonna tilt that way, right? It's gonna tilt that way. So if it tilts that way, then for normal cases it's not good, but for this guy it's gonna be beneficial because that's gonna give me a little bit of flaring, transverse expansion, and a little bit of intrusion. Now, when we're doing that, we have to be very careful that occlusally, the implication of that, okay, transverse dimension and vertical dimension, we're thinking that this one will intrude and expand, right? But on the long axis of that tooth, let's say these are the cusp, buccal and palatal cusp. If you intrude it, it's going to go like that. That's not going to be favorable as well because there's going to be a lot of premature contact on the palatal cusp. Hence, what we have to do is control that. So how do we control? We place a very thick wire, okay, with a little bit of a palatal torque. So once there is a pull on the buccal and also there is the application of the wire into the bracket slot, they're going to counteract each other, and after they counteract each other, hopefully the net is that they fully intrude along its long axis. Okay. Now it sounds very plausible. It sounds plausible, right? In a sense that, hey, that makes sense as far as physics is concerned. Okay, so the problem is that there's biology as well, and when there's biology, there's heck a lot of variables. Okay, the dentist, okay, the patient, bone quality, response of the patient, frequency of visits, activation of force, how much force is activated, the friction, and so on and so forth. Okay, and that's where it's going to be very difficult. Okay, so we have to play it out, try to consider all these factors, and then come up with a good solution for that. Okay. And as for the lower, we can also place TADs here. Okay, I usually place it distal to my canines, and then my activation force would be from the TAD to the 4 anteriors. Okay, 4 anteriors, and then down back to the distal of the canine. All right. Now, in cases like this, and as I did in this patient, okay, what was I saying? The TAD. Okay, so the TAD will be placed here. So my experience with this patient is that I had difficulty of placing or keeping the TADs in its place. Why? Because poor bone quality. Okay, poor bone quality. So it kept on falling off. Why? Because if you remember in the discussion of the panoramic X-rays and the diagnosis, is that the what do you call this? The quality and quantity. First of all, is the quantity of the bone. Okay, so the presence or the quantity of the bone is good if there's a presence of the teeth. Okay, so and then the next is that the quality of the function in that area, the quality of function in that area is that's where the quality, I'm confused. Okay, so the quality of the bone is related to the quality of the function in that area. The higher the quality of function in that area, the higher the quality of bone, and vice versa. I mean, in the opposite sense. Low function, low quality of bone as well. And that's why for this patient, his lower arch seems like it's such. Okay, so so to put it, do you have to treat the lower immediately? No, not really. What you're supposed to do is first fix the upper and then go on to the lower once you're ready. Okay? Okay. So clumsily, this is how it looks like. Now, as you can see, there's a missing 6, right? And these teeth have drifted. That's a natural tendency, but not with all these teeth together. And at the same time, crowding like this, how does that happen? So look here. He usually closes his mouth. He has this mentalis reflex, remember? And actually for this patient, he's that type of patient, when you put that mouth mirror in this lower lingual area, he really tends to eat that mouth mirror. Okay? So that mentalis muscle is very strong for him. And and the reason why that is happening, because the position of the lower jaw is incorrect, and we have to correct that first before we're able to correct something else. Okay, so that's where we have to intrude at the beginning. Any question? Okay, so for this morning's topic, hopefully we're awake. Our topic now is going to be on Ortho Perio and Ortho Endo. Okay, so now these two things are actually directly interrelated. Masyado ba maingay si Pao? Okay lang kayo? Hindi kayo nadidistract? Kasi kung gusto nyo, pwede tayo mag-typo muna. O, cool lang kayo. Okay, sige. So, aside from the common notion, the common notion is that ortho is only ortho. In fact, they only think it's only dontics. They sometimes even don't think about the bone. Okay? And you see, when you say that it's dontics, then you're talking about the vitality of the tooth, right? The health of that tooth. And when you're also saying ortho separately, you're also referring to the periodontium, which is composed of your periodontal ligaments, your bone, and your gums, right? Basically, the support of your teeth. So now, when you put these two terminologies together, orthodontics, that's where it becomes a problem, because when you say orthodontics, it doesn't seem right, because now we're talking in a whole different context of aligning and fixing teeth aesthetically and functionally. And we tend to all the more move out endo and perio. Now, I would say that these are actually in full interrelation, and this is somehow the topic that would really teach us that we do have to be careful about the movements of our teeth. Okay? So, as orthodontists, usually the effect on the students is that they become technicians or they become mechanics. Let me just place the braces, let me just place the wire, let me just level it in line, and just wait for it to get straight. In our typodont exercise, that's what we do, right? We're not thinking about the patient, because the patient isn't even talking. I mean, he's not even saying ouch, because he's a plastic model. So, in that sense, there are a lot of students who would graduate from ortho programs that would think that, hey, I'm just doing this, when actually you're also playing around with the periodontium, you're improving the support, and also you're improving the quality of life of that tooth. I mean, imagine if you're in a crowded situation. Or don't you agree with me that in crowded situations, the tendency for class 3 and class 2 restorations are really high? Yeah, because it can't self-cleanse. And if it can't self-cleanse and your patient is also lazy in flossing, what's going to happen? Food accumulation and then caries. And caries would either lead to what? Or food accumulation would lead to what? Either caries, endo, which is the end point, or perio, wherein there's food impaction areas and there's going to be an inflammation. Right? And if these things happen in the mouth, then we're not really giving good quality kind of treatments. So let me just discuss in the orthoperio first, okay, the factors and how these are interrelated. I will also talk about how it goes full circle in terms of ortho and perio, the treatment, the periodontal limits, and the sequence of treatments, okay? So, you remember this, right? So for malocclusions, the main disease is malocclusion. We have effects on the teeth, the muscle, the bone, the joint, and also the periodontium. So let me just go directly to the periodontium, because that's the main topic. So for periodontium, it usually would lead to either periodontitis, bone destruction, or bone production. Okay, bone destruction or bone production. So let me just recap for this situation here. Loss of the lateral incisor, right? So that central incisor drifted distally, and what happened in effect was the marginal ridges of this upper central incisors are now hitting on this lower incisor, and as it hits on this lower incisor, remember, it receives a lot of pressure every time that the patient chews, every time that the patient would swallow. Imagine swallowing your saliva throughout the whole day, and that receives pressure. You can't swallow without without biting. Okay, try to do it. It's difficult as hell, right? So our normal situation is we bite and then we swallow. So in that sense, when there's a lot of pressure that the periodontal ligaments receive, what happens is a lot of pressure means a lot of resorption, right? Pressure, resorption, tension, apposition. So here, it's receiving a lot of forces, not only when the patient is swallowing, all the more, think about it, anterior guidances. If your marginal ridge is right there, and it's not being split by these teeth over here in terms of the load, what's going to happen? It's going to receive all the force and, again, pressure. So normal functional movements for this patient, we already deem that there's going to be periodontitis. Now, at start, it's going to be sterile periodontitis, right? So there's not going to be any bacteria yet until there's inflammation. Once there's inflammation, there's going to be pocket formation, and after pocket formation, what's going to happen? There's going to be influx of bacteria. When there's influx of the bacteria, now it's a non-sterile periodontitis. And this could happen generally, or this can also happen locally. So for this patient, it's happening locally. Now let's just try to snap out of the matrix. I mean, no, not snap out of the matrix. Let's go into the matrix. Have you watched Matrix, or am I that old? You guys know Matrix movie? Keanu Reeves? Limot na? Okay. Ha? Bata ka pa. Sucks. What a shame. Okay. All right, but you know Keanu Reeves, right? Okay. So, but it's a Hallmark movie. At least by the title, you know it, right? So, the Inception. Have you watched Inception? Brad Pitt nga ba yan? All right. Forget Inception. Matrix na lang. So the movie was about all these people would have like plugs over here at the back of their heads, and the matrix is reality. Augmented reality. Augmented reality. So it seems like the situation is like the real world. Okay, let's say this is the real world, and what's happening is everything that is happening around this world is basically happening, and it's happening for what's happening. It's just happening, status quo. But the concept is that you can also snap out of the matrix by what you're gonna. This is very hard to explain. But okay, so since it's augmented reality, what they do is they snap you back into actual reality. And actual reality is they plug you off that chair or that machine, and suddenly they wake up in a room where there's like a command center. So here in this command center, they're like instructed to, okay, you fix this, so that the matrix won't, hindi masisira, hindi siya mahahack, hindi magkaka-problem yung matrix. So they're like technicians, but of course, because it's an action movie, they have to kill like viruses or people as well in that reality, who are trying to destroy that whole matrix. Otherwise, everything will just explode. So, I'm just trying to. Okay. So that's what the matrix is about. And when I say right now that let's snap out of the matrix, snapping out of the matrix is like, okay, wake up, get away from what's happening in the contemporary world. Let's now wake up in this room. Sorry. What the hell am I saying? I'm confused as hell. Okay, let's snap into the matrix. Let's go into the contemporary world. Okay? Now, in the contemporary world, what's happening there is that when you show this to a GP or even a ortho or some perios, they think this is a perio situation. We have to fix that, and this is not an ortho problem. Ortho is going to be last because we have to rehab first. We have to make this healthy. Understand? So what they're going to do is scaling, root planing, maybe bone grafts and gum grafts. I don't know, what do you call that? But they're going to try to heal this whole scenario here. It may heal, but the question is, how long is it going to stay healed? Because what I'm telling you right now is that by etiology, what is it? By etiology, there is a problem that is happening over here where the pressure that 3-1 is receiving is too much from what is coming from 1-1 and 2-1. So, let's go back. Let's get out of the matrix, out of contemporary. And now let's visualize about this situation here. If that is the cause, doesn't it make sense that we have to fix the cause first before we do something here? Right? Quality of bone is dependent on the quality of function. So we increase the quality. We reduce it a little bit. Immediately, what you can do, okay, but doesn't mean you should, you can reduce, do enameloplasty on the ridges. Doesn't make sense if you're going to do it on the incisal edge, right? But then what I'm just trying to say is you take it out of contact, and that would somehow remove any hard pressure on that tooth, and that would somehow heal gradually by itself as long as it's kept clean. Okay? And then you go to Perio, and then you ask the Perio to fix this while it's out of contact, while you're fixing all the other malocclusions that are present. So, in another world, if there's not too much pressure, there's now going to be too much pressure, tension. And in this case, there's bony exostosis. And the reason why it happened was because the anterior guidance was poor. And I would tell you that I received this patient excellent leveling and alignment. Slight crowding in the anterior where the laterals are hiding a little bit behind, but it's not that bad. But I received him with all these bony exostosis, and primarily it's because of that heavy contacts in those regions of teeth over there. The problem here is that once it builds, it's not gonna break down again unless you put some pressure or you remove it by exostosis. So going into, let's say undergrad, right? What does undergrad tell us when you see something like this? Oh, I have a special surgery case. Let's open him up, remove that exostosis. Yeah, we can recall him for after about a week and see that he has healed, but let's try to recall him after 2 years. We're gonna have that exostosis again. Question? I'm sorry? It's attrition. He's grinding. It's also because of that local area where it's coming in contact. But usually it's because of attrition, in a sense that the posterior teeth are receiving lateral forces instead of longitudinal forces. Okay? Yeah. So, and in another sense, lingual torus is also a cause of malocclusion. And this is my teeth, and I have premature contacts over here in this area, and that's why I have a lot of bone over here. Okay, so I have 2 premature contacts. One is over here, and one is over here. Depends on what time it is of the day and what I'm eating. In that sense, okay? So palatal torus now happens in a sense that there's balanced right side contact and there's balanced left side contact. However, left and right are not balanced. So right hits first and then left, or left then right. So they get it at different times, and what happens is it's the palatal suture that flexes, and as it flexes, that's where the bone production would come in. Okay, so again, when you're going to do surgery, yes, you can remove that torus because you might need to do a denture, maybe, but then you have to remove the cause first, balance the occlusion so it won't come back again. Okay? Yep. Yeah, so we have a torus right there. Okay, so this patient developed a torus because, as you can see, this is the first appointment with her, and as you can see, the positions of these first molars are well rotated, and that's the reason why there was an imbalance on both left and right. Okay, so just fast forward into this. Let me just go into the bone, and for the bone, right, it comes out as periodontitis, bone reproduction, or bone reduction. And the reason why is because there's an increased frequency of what? Pressure or tension. Somewhere, somehow. Okay? Here. So our dilemma as we approach this perio, orthoperio region is which one comes first now? Perio or ortho? Well, later when we talk about perio, you can see that there's a malocclusion first, and then there's perio. Or sometimes there's also perio before and then malocclusion after. Okay, but this comes from the book. My stand is that there's always malocclusion first and then perio, and that's always the process. Why? Because you're only going to have perio not only if you have poor oral hygiene, but if you have poor self-cleansing areas. If you've seen farmers dental service na mag-dental service na, I'm sure. Rice farmers, okay, rice farmers, if curiously enough, they usually have dentitions that are complete, clean, but may perio, right? Halos kompleto, high fiber diet, but usually pagka kuwari nasa north, nagngunguya sila nung ano. So it could be poor oral hygiene or it could be some habits like that. But all the teeth are kept inside. When you come down to Manila, it's a whole different scenario because sa Manila naman, loss of lower sixes. Usually pag Baseco, di ba? Nakarating ka na Baseco. Wait, was I? Okay. So, when you come down to Manila, it's full of loss of lower six, especially if you had the dental service already in Baseco. Have you? There's always a dental service there. And you're going to see that there's a lot of loss of teeth as well. And these different scenarios would usually happen, and I would attest to this, because of malocclusions. Okay, and that's where it always starts. So definitely the procedure, just to put it quickly, is that you have to clean it first. Make sure that there's no mobility. And then when you have decreased the mobility, that's when you start your ortho. Okay. Now, if ever you're gonna start ortho in perio challenge cases, you have to just make sure that it's clean at least. Okay. So it doesn't really have to be without mobility. Sometimes mobility is okay, depending on the degree. If it's third mobility, of course, that's an extraction. If it's second mobility, but you still have bone support, then you try to keep it. Okay. All right. So the factors for for perio is, of course, gender. For females, especially when they're pregnant, their bone quality is much more lesser because the calcium requirement of the baby is really high, and it takes the calcium of the mother. Genetic factors, of course, but not so much, okay? Because in the genetic factors, unless it's something that's serious, you can always curve it, okay? Meaning, say you can increase the pressure on your bones. Say, for example, what do you call this? Have usual exercises, and if you have usual exercises, what's going to happen is there's going to be more pressure on the bone, and the quality of your whole bone in the whole body is going to be higher. Social status, of course. If you're rich, then maybe your bone quality is lesser because you don't really move that much. But if you're that poor, let's say, for example, compare a farmer, right, where he always moves, he bends down, and he always works, he always carries. You see these farmers that they have big bones, right? Their feet are wide because that's the demand of their body. General health, of course, how you take care of yourself, host immune factors, and smoking. Now, smoking is indirectly related, but it's a factor, okay? It's indirectly related. It's more of the interleukin production, and which would cause the deterioration of the bone. Okay, so for the local factors, you have oral hygiene, of course, untreated dental caries. Definitely, when you have these dental caries, not only does it cause perio, but say, for example, there's an opposing, and now you have this, oh my goodness, I forgot. Yung wala na yung buong crown, tapos may pulp polyp ba? Nalimutan ko na. Okay, yung may pulp polyp. Alam niyo yung gano'n yung tsura yun sa mga bata usually na hindi mo pwedeng i-exo. For those kind of situations, the upper teeth tends to super erupt into that lower teeth, which is not good as well. And once that upper tooth super erupts, now the contacts of your teeth are disrupted, right? Because there's supposed to be a contact point, and that's where the teeth, that's where the food would stop. If it hangs low, and the contact point now has changed, where it's it's in the undercut of the super erupted teeth, then the food will go in there, and once it goes in there, that's where the perio would start. Dental restorations, definitely, especially if it was done carelessly without reduction of the overhangs. Microbiological factors, but it's related to oral hygiene, crowding, and definitely occlusion. Okay, so as shown in the previous picture, or in the previous case, you don't have to have like bad crowding. It could just be because of poor function. If you have poor function, you can already develop perio. Okay, so it doesn't have to be crowded. It could actually be level in line, but still be bad. Okay, so we have periodontal disease here, and periodontal disease basically leads to the migration of the teeth. And as it leads to the migration of the teeth, it's usually because of occlusal discrepancies or the increase in plaque and bacterial count. Okay, so when there are occlusal discrepancies, these are usually caused by the altered topography of the teeth, the gums, or the alveolar bones. So the flow here is that when there's an altered topography of these structures, or relationship of these structures, then there's going to be occlusal discrepancies. So in the gums, it could be like frenums, right? Alveolar bones, if they're thin biotype or thick biotype. For the teeth, it could be the shape, if they're much more triangular than trapezoidal or square, then of course the accumulation will be much more different. And that's where you can develop these occlusal discrepancies, and as you do, you're going to have an increase in plaque and bacterial count if you don't clean it, and then it will develop into periodontal disease and then the migration of the teeth. Okay? So let's look at the result of your periodontal disease in terms of what happens after perio. Okay, after perio. So you can develop an increased overjet and overbite. So if you think about it, when you have a malocclusion, and then there's poor, anterior guidance and lateral canine guidances, then it's gonna get worse and worse. So say for example, our patient, the very first patient that we talked about, where there's a big overjet and a big overbite, I mean, imagine how bad that occlusal relationship is, functionally and statically. So statically, it's already impinging on the upper gums, right? For the upper anteriors, it's already deflecting the lower lips. In the same way, the overjet and overbite, when anterior guidance happens, there's an extra effort that happens. So in such a situation, when there is an increased overjet and overbite, it just gets worse and worse, most especially if there's perio. Just a review, why do we need the anterior guidance? For closing, okay, when you close in your anterior guidance, the importance is that it leads or guides the lower jaw into a position where your posterior teeth will hit longitudinally, not laterally. Okay, because that's the design of your posterior teeth. And when you try to open through your anterior or canine guidance, remember, it protects the other teeth at the posterior, but aside from that, it also helps guide the muscles into disoccluding the jaw. So as it helps disocclude the jaw, then there's lesser muscle effort because it knows where it's gonna go. So what happens is, if there is poor canine or anterior guidance when you open your jaw, what happens is your jaw would wiggle. Okay, so overjets and overbites are basically that important when it comes to your anterior guidance and how it relates to your whole mouth. Next is the rapid deterioration of the occlusion, of course, because it's never going to be it's going to be a never-ending cycle. So it's going to break down, it's going to destroy, it's going to accumulate, it's going to break down, and it's just going to be progressive in nature. Okay, either acute or chronic. So we have to be there at the perfect time. And the perfect time, say for example, is at your age. And we usually see patients who are at the same age as we are. Upper anterior spacing, of course, because they tend to flare out, especially if there is a poor anterior guidance. Crowding of the lower anteriors, extrusions, loss of opposing teeth, anterior flarings, okay. So we could look at this in two perspectives. One is, if the patient has this, then we might think, does this patient have perio? Or is this patient a candidate for perio? And in the same sense, when we're finishing cases, in terms of the objectives, we have to keep this in mind, that the patient has to get good oral health care and good stability thereafter, so that these things would not happen after, okay? And final is the collapse bite. So here is a malocclusion caused by periodontal ligament, periodontal disease. So as you see, there's periodontal disease going on. It could have started in a lesser severe situation, but because of the aggressive nature of this periodontal disease, loss of the supporting structure basically made it go in different directions, right? So this is a malocclusion, again, caused by periodontal disease. Now, this is something which is a malocclusion as well, causing periodontal disease, wherein there's an occlusal discrepancy where the lower teeth are hitting the palatal of the upper. I mean, the soft tissue of the upper. And if it hits the soft tissue of the upper, usually in cases like this, the palatal part, you're going to see it's a little bit reddish. Okay? And here, periodontal disease caused by malocclusion. So again, self-cleansing areas are key factor here. And when you, let's say for example, in normal overjet and overbite patients, the upper lip would clean the facial side of the upper anterior teeth. It can't clean the buccal surface of the buccal area, right? Because this one is presented by what do you call this? The usual accumulation of calculary deposits, right, on the upper buccal of the posterior. Not only because the mineral deposit of the salivary duct over here, but food also tends to go over there, and whenever we smile, we pull it back. And that pull back basically just slides that food between the gums and the tooth. And for the lower anterior, very small accumulation of lower calculary deposits on the lower anterior of the lingual part is supposed to be present, because that's basically normal, but too much is also bad. Not because it's brushing, but most likely because maybe the tongue position is not correct and it really can't clean that area. The tongue is supposed to clean that area. We usually, if you think about it, crowded cases for the lower anterior would have a lot of this calculary deposits in between, especially for those that are buccally located, because the tongue cannot reach those areas. So in this sense, for this patient who has a reverse underbite, and it's not pseudo, okay, it's a real one. A pseudo reverse bite or a pseudo class 3 won't usually have this inflammation, because they're still able to self-cleanse the upper. But for these patients, because the teeth would tend to pack all the food on the cervical area of those upper incisors, then we have this inflammation of that region there. Okay, another periodontal disease caused by malocclusion. Loss of lower 6 in this patient. As you can see here, generally it's straight. It's all these teeth are upright. But I think what happened along the area, along the timeline of this patient, was he lost his lower 6, and after the loss of lower 6, this molar here basically dumped forward, not only because of the wrong positions, and we know all of that, right? The auto-rotation and dumping and mesial tipping, but also because of perio. As we can see, It's still inflamed, but it's not red, right? But it's inflamed, and there is some loss of bone support for that tooth. Okay, periodontal disease caused by malocclusion. As you can see, there's the inflammation of these gums over here naturally because of the inability of the lower lip to cleanse that anterior area. Okay, here, another periodontal disease caused by malocclusion. Now, this patient not only had a braces, but he also has poor oral hygiene techniques. Okay, poor oral hygiene techniques. As you can see, there's accumulation over here. This is after cleaning. That's why there's still some blood and calcular deposits that are loose. This is when I received this patient. Okay. And I gave him oral hygiene instructions, and somehow he improved a little bit. But because of the contraction of these teeth all together, he wasn't able to clean in between, and that's why he has inflammation in those gums. Periodontal disease caused by dentist. Now, if you look here, and I think I lectured this one already, look at the thickness of that bonding cement. That's not materia alba, huh? Those are laminate type bonding cements. I don't know what the hell she was thinking when she did this, but those were that thick. And if you look at the general welfare of the gums, it's inflamed, right? In the reading. So now, aside from that, the way that this dentist as well is activating the force, look, power chain from 6 to 6. Those forces are so high that it's gonna cause a lot of pressure along the whole arch. It's either gonna soften, resorb, or do something or worsen these scenarios here. So here's the problem, is that when you're doing ortho, when you're moving teeth, there's inflammation, and this inflammation is sterile, and that causes resorption. That's what causes movement, right? Now, when you have perio like this, inflammation, non-sterile, plus sterile inflammation, then there's going to be double inflammation, and then what you can expect is teeth that are actually mobile. Okay? So we have to fix one or the other. Now here's another one. This is my brother. It's periodontal disease caused by appliance. I do see him every day. I did see him every day when I was treating him because he lives just in the other room. I also see him when he brushes his teeth. He does smoke. He did smoke at that time, but not that much because bawal mag-smoke eh. As in, tumatakas lang siya mag-smoke, and he's not that much of a chain smoker. I don't know why he smokes. But then the smoking didn't really do anything in terms of the inflammation, but there was just a lot of accumulation of calcular deposits in those inflamed areas. We always clean it, we always remove, and they were already black to a point that he's already in pain when I do it. So to the best of my knowledge, I did remove as much as I did and as much as I could. And to the best of my knowledge, even through x-rays, I did not see what do you call this, calcular deposits. And I do cleaning every time I see him. Okay, so sa second molars, wala siyang periodontal disease. So actually, when I placed the appliance, what he got was inflammation because of allergies. So he was allergic to the material. So because of that allergic reaction, there's inflammation, and after inflammation, accumulation, and after accumulation, periodontal disease. Okay? So, going back here, we look at ortho and how it relates to this whole flow chart here. Something like this is that because of periodontal disease, it causes migration of teeth. Now, the migration of teeth, I have to do ortho treatment, but when I do ortho treatment, it now increases in plaque and bacterial count. And when I do ortho treatment, my objective should be to return the protective equilibrium of this patient, meaning to say that I have to restore functionally this patient. So when it comes to periodontal diseases patients, we can't just treat them, okay, we can't just treat them, what do you call this, aesthetically. More importantly, we have to treat them functionally, okay? So we have to provide good balance between the tooth, the teeth, the bone, the joint, and the muscles, okay? And once we do that, when all of these are already in protective equilibrium, the effect is that these treated patients maintain better hygiene. Now this one is post-ortho, okay? But within ortho, what happens is, okay, factors that could cause periodontal disease could be space closure after extraction, and also iatrogenic factors as shown by the previous cases. Okay, so it's paikot-ikot lang. And it's very tricky because automatically when you place braces, your patient is already a candidate for ortho. For perio. So definitely you have to monitor your patient, make sure that no perio is developing. So cleaning should be a part of your treatment plan. So cleaning every 6 months could be free. But cleaning between that 6 months, let's say 2 months, 3 months, or every month, you have to clean, you have to charge your patient. Okay, so this is my system in the clinic. I do, because I do a lot of charity work as well, and I don't usually charge for cleaning. Okay, I don't usually charge for cleaning because I feel like it's my obligation to make sure that nothing bad is happening in that mouth of the patient. But when I see that the patient is uncooperative to a point that they're not even taking care of their teeth because they get free cleaning from me, well, hell no, I'm gonna charge you. And this is also the same tool that I use in terms of motivating especially young teens, because these young teens are very lazy in terms of brushing their teeth. And when they are, I tell them, okay, hey, your mom pays every 6 months for free, pays for your cleaning. Okay, your mom pays every 6 months for your cleaning. That's a free cleaning, but if ever I have to do it in between, I'm gonna charge you from your allowance, and I'm gonna tell your mother that you have to pay me using your allowance, okay, for your cleaning. Then they start, hey, that's my allowance. I don't want him to have a part of my allowance, so I'm going to take care of my teeth. And it works. Okay? So it goes around and around, and that's from a standpoint of starting your patient without perio, but what more with patients who start with perio? Now, those cases are much more challenging. In cases where it starts off with perio, what I do is that, of course, I ask my periodontist to fix it, to clean it, and make sure that there's no more mobility. And once mobility has been removed from the equation, and everything is clean and stable, that's when I'm going to start ortho. I'm going to show you a case later. So with cases of loss of lower six, basically when you say protective equilibrium, instead you have to fix the whole human masticatory apparatus in its proper position, okay? Now, how does perio relate furthermore to ortho? When you're treating your case on a normal situation, your line of action or your center of resistance is in this region, right? So when you pull the teeth, you want your force to be directed in that area so it moves translatory, right? Now, if you have a periodontal loss, say for example like this line of action changes. Because when you're applying now your line of action, you have to apply it higher so that it moves accordingly to the type of movement that you want. So if your type of movement, if your bone support, you always have to check for your bone support in order for you to know how high you need to put your force. Okay? All right. Okay, now this is for more for periodontists. So for periodontists, for horizontal loss, it has a chance to heal. Okay, but for vertical loss, your chances are very slim. So for horizontal loss, you can generate new attachment. Okay, but you have to set the situation very perfect. Remove the calcular deposits, make sure that it's completely, absolutely clean, and then you have to improve the occlusal contacts so that the contacts that that area would receive is good. Again, the only way that you can generate new attachment here is if you have high function in that area. If you have high function in that area, then you're gonna develop high quality. Okay, so if you don't fix it, it doesn't make sense. And in the vertical loss, there's no new attachment that's going to happen, but there's going to be improved. There is a chance for you to have improved gingival levels. And you can do this by the help of your GTR, or guided tissue regeneration, or by injection of your growth factors. Okay. And when it comes now to the limitations of your periodontal ligaments, we have to think about this in two scenarios. So one is sagittal and the other one is transverse. Sagittally, we look at it at the ceph, and we look at the limitation of this part, right? And basically we look at when you're going to move these teeth, when you move them forward, what's the effect on the gums? Is it going to stretch the bone? Is it going to stretch the periodontium? Is it going to make it? Is it going to keep it maintained in a very healthy situation? Right? So, and transversely, as you can see, we have a constricted arch over here. So what we can do is when we develop it, can it accommodate that whole new position? How did that happen? Well, of course, there's an expansion on the posterior segment, but look at my my projection here is that this is the position of the teeth inside the bone, and I have a lot of bone buccally over here. That means if I move the teeth buccally, I'm still going to have bone over there. So, ano nangyari? Here, okay? So when I move the teeth buccally, see now it occupies that whole bone area on the side. Okay, so we have to check if there's bone and if the bone or the periodontium could accept the movements that we want to apply. Okay? Who's that? All right, so this sequence of treatment. Ano? Ikaw ba yan? May kumatok ba? Gulo mo ba? Kanina ka pa nang gugulo sa amin dito. Okay, so the sequence of treatment. So you have to make sure that it's healthy. There's no pocket greater than 3 millimeters. It's well maintained. Okay, and being that it's well maintained, there should be hygiene motivation. So there must be psychological helping of the patient. This is something that we don't incorporate in the Philippine setting. We don't talk about psychology, right? There must be a correction of overhanging fillings and making sure that all those areas are without overhangs. Caries restoration, periapical lesions are fixed and healed, and there must be a sense of co-responsibility of your patient with the whole treatment and secondary malocclusions. Okay, you're gonna know more about co-responsibility when you treat patients who are teens. Teens are like, they're careless human beings, you know, they're pains in the ass. These patients don't really care about what you're doing. What they only care about is that you have braces over there and that they're sparkling smile. Right? They don't even care if it's moving. They don't even care about what you're paying up, what their parents are paying for. They think that they deserve it because their classmates have it. So, you know, I have fun with teens because it's a scaring game that you can play with them. So what I do is I scare them. Like I said a while ago, you pay for your own cleaning with your own allowance. Or I also have to explain with them thoroughly and scare them with signatures, and also with their parents in the room, just to show them what co-responsibility is towards their treatments. Okay? And then that's when ortho should come in. And as you do your ortho, your objectives should be force stability, where you have functional equilibrium and complete restoration of the whole dentition. Any missing teeth that caused the malocclusions should be refilled again. Okay? Right, so here's my patient. She's a periodontally compromised situation, and as you can see, look at the situation over here. That one is rotated. Buccally, it's super erupted, no more bone support. But in this scenario, what's happening? Is it the super eruption of the teeth? It's a periodontal case, yes. But the question is, did it super erupt, or was there a recession of bone? I believe that it's a combination of both. It super erupted and there's a recession of bone. Now, another scenario would be if you have these teeth over here which are good in position, if there's a recession of bone, that's something you cannot intrude. Okay, if there's a recession of bone, such as in this case, that's something that you cannot fix. But over here, since it's super erupted out of the alveolar bone, then this one is something completely good in terms of its prognosis. Okay? Now, funny thing about this case is that I wasn't consulted when the perio met this patient. So what I did was, she just called me up and said, "Hey, Doc Pao, I have a patient for you. It's a really challenging one." And whenever I hear that, I always say yes without looking at the pictures. And to my surprise, when I came into the clinic, I said, "Well, what the hell? Why did you even try to save it? And why didn't you just extract it? I mean, there's barely like 1/3 of the root that is hanging onto the teeth." And then of course, I was there already in front of the patient. I can't say that. When I started jiggling these teeth, they were ridiculously stable. They weren't moving. They were actually non-mobile. I said, "What did you do here?" She said, "Root planing and all of that." And okay, fine. So now, of course, I can't tell the patient, "Have your teeth extracted." Why? Because that would undermine the treatment of the periodontist, right? Oh, the patient would say, "Well, why the hell did you heal this when this doctor will tell me that I'm just gonna extract it?" So I can't say that. So what I did was, "All right, how far will you take it to fix this?" "As far as it takes, as far as we need to." I said, "All right, cool." So I said, "Well, let me risk my life. You're a crazy patient. I'm a crazy doctor. It's a match made in heaven." So this was post perio, and as you can see, there's some more calcular deposits, and maybe a little bit over there. But generally, it's already okay. But look at the bone support. I said, "What the hell? Why would you still try to save this?" Okay. Let me just go back here. Remember, good occlusion, good function, good quality of bone, good self-cleansing areas. Right? Poor function. Okay. I don't know what the hell happened over here. Okay, but most likely what I'm thinking is that because of the round bite over here, she tried to adopt, and the adaptation basically caused a lot of stress on the canine guidances and anterior guidances that it just screwed up the teeth over here. Okay, anyway. So, acceptable bone health over here in the posterior, and here's my treatment plan. Now, in perio cases, when you treat them, you have to use very, very low forces. Okay, very low forces. Why? If you put too high forces, because there's lesser bone quality and quantity, you might burn off all that bone. Okay, so you have to keep it healthy. So, excuse me. And my other one would be my anchorage. So, for the low force, what I used was self-ligation brackets. For my line of action, okay, for my force generation, it's low, so I'm using self-ligation. But for my line of action, in terms of where I'm trying to bring these teeth, what I'm doing is I use TADS and also a transpalatal arch. Okay, so my transpalatal arch is modified, custom modified. There's no such thing as you can call this type of TPA, but I basically used it for attachment. Okay, just as an attachment. So the reason why I use it as an attachment is because I need the proper line of action where it's pulling it palatally and also intrusively. So I have two forces coming from the buccal and also coming from the palatal. So net force is going to pull it inward. There's no room for mistake in this kind of patient, because if you move this slightly buccal, the root's going to come out. You move this slightly move it slightly palatal, the root's going to come out. Move it slightly buccal, you might burn off that buccal bone in that area. So I use a combination of both, right here. And as you can see, I'm using elastic threads. Again, elastic threads elicit just the right amount of force. Okay. Elastic thread within 3 weeks. So within 3 weeks, I reappointed the patient and I said, you know, I was scared to hell. I'm gonna see you after 3 weeks. I can't wait for 4 weeks. So I see that the teeth are moving appropriately, and what happened was, the first thing I did when I saw her was I tried to check if the tooth was moving. I was surprised it wasn't moving. It was actually mobile. So that means there's good bone support in that area. And after 6 weeks, I said, I'm on a roll. So far, everything is working according to my plan. And now we can see the lower interior. Right, better. And at this point, as you know, as you can see, there are lingual buttons, and those lingual buttons are hampering my canine guidance and my interior guidances. So I had to remove them after. Okay? So now that I'm in this position here, I'm using this very thick wire already in order for me to be able to control the roots. Okay? Here's the CBCT. And we did this about 6 weeks after. And this one, basically, they do look like they're coming out, but they're not. Because when you're doing these computer-generated images, they remove a lot of noise. And when you're removing a lot of noise, you also remove a lot of bone. So that means that in this scenario, there is actually a lot of bone that is surrounding these teeth. So generally, we have positioned these teeth in their optimum position. Now it's up to the bone to heal itself and regenerate itself. What's my role? To restore the position of those teeth into a functional position. Okay? So I remove the buttons and place the lower and try to level the line. And that's where we now have Endo Perio lesion. These tooth cervically and occlusally are pristine, no caries, and when that was traced, basically the gutta perca came out, I don't know, somewhere here. I didn't do it, okay? All I'm doing here is perio. And that note, alright, so let's continue on. So ortho endo. Now for ortho endo, the idea is that we're not talking about the periodontium or the surrounding structure. Right now what we're talking about is the internal structures, the nerve and the blood supply, and the health of that tooth. Okay? Now in ortho endo, usually what happens is it's ischemia. Okay, and ischemia basically is the loss of blood supply, not only from the sides, okay, from the periodontal ligaments, but rather from the apical edge or apical tip. Now, from the apical tip, usually movements when they say, for example, intrusion. When you intrude the tooth and these structures, these blood supply and nerve supply would get impinged, the situation may be that there might be loss of blood structures. Okay. Now we have to understand as well that when you're moving teeth, there's a lot of things that are going on in a in a genetic level. Okay, so in a genetic level, like interleukins and all of those stuff, or rankle genes, all of these genes would somehow trigger a response in the bone. And these responses in a macro sense is the resorption and the apposition of bone. But, okay, we don't know because of these variables how much of these genes are actually being secreted in those areas. So when these are secreted in those areas, there could be an overreaction of the resorption, there could be an influx of these genes into the tooth or outside of the tooth in certain areas that are not happening, where it's not supposed to happen. So you see, we have to understand when we're moving teeth, we're disturbing the homeostasis of the tooth in that certain region. So it can either respond bad in the perio or it could respond bad inside the tooth. Okay, so ischemia can be caused by heavy pressures or by very thin areas in the periodontal ligaments. For older patients, remember the periodontal ligament space is much more smaller. So when you move it to the slightest, you can already cause ischemia. For younger patients, because their periodontal ligaments are wider, or so that space is wider, when you move these teeth, there's just a lot of room for that tooth to move, and ischemia may not happen as good or as bad. So that's why when we talk about treating patients periodontally, it doesn't really matter of the age. What matters is how much force you apply. The responses are going to be the same, but the difference is just how much space is going to be available. That's why for teen patients, it's much more easier and we can be much more careless. But when it comes to older patients, we have to be very much more careful because the space is very thin and we don't have really that much area to move. Okay, areas of void of blood circulation, which is ischemia, and of course sterile necrosis. Now, sterile necrosis is something that can really happen. This usually happens over a period of maybe about 20-30 years after ortho. After ortho that had high forces. I had a professor in my undergrad. She's ortho as well. I'm not going to say the name. Her teeth are perfect set. She teaches ortho as well, but her teeth are yellow and blackish as hell. And the reason why it's yellow and blackish as hell is because she remembers that when she had ortho, she had great forces. She was an extraction case, and what happened was because of these great forces, it just caused the sterile necrosis. That's why her teeth are kind of dark and yellow. Okay, so a non-vital or degenerating tooth that is undergoing tooth movement has a higher chance for active resorption process. So therefore, we cannot move teeth that are orthodontically endodontically compromised. So we have to look out for fistulas like this. Now, for this patient, there was a delay in terms of finding out that this patient had a fistula. It was a long time that this patient had a fistula already, but I just wasn't able to discern it because of its proximity to this frenum just buckled to it. Okay? All right, so we have to treat it first and then do ortho. Okay, so for the ortho treatment phase, when we look at the effect of the ortho treatment to the pulp, we have to understand how it affects the tooth. So we look at it from two perspectives. One is optimum and the other one is in heavy forces. So first, let's go to optimum forces. So for optimum forces or light continuous forces, the tendency is that you can have none to mild pain. In fact, what's going to happen when you're treating your patient would feel that there's something different, but there's no pain. Okay? That's the correct amount of pain that your patient should leave your clinic. Okay? So when you're adjusting and then the patient says, ow, 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 then that means you are applying too much force. That means you have to reduce the force, or let's say when the patient is already paying and then the patient says, this is too tight, right? And when she says that, or he says that, then you just have to smile inside and say, oops, I placed too much force, okay? So your patient should not feel pain at all. They should feel something different, but not pain, okay? So that's what I always ask my patient, is there any pain that you're feeling? They say, nah, mamaya pa to, siguro mga 3 hours. Which is exactly the point. So after 3 hours, that's when the pain should elicit. Okay? Next, hyperemia is possible. There could be decreased blood circulation, of course, because you're displacing the teeth in certain areas and there's a hampering of these blood supply. Okay, pulp inflammation could happen. And when pulp inflammation happens, there could be a hypersensitivity with widening of the periodontal ligament. So how do we manage? The way that we manage, if symptoms are significant, remove the arch bar for a month and then observe. If the pain is removed, then that means we're just doing too much force. So what we have to do, okay, is we just have to let it rest, let it heal, and then reapply the force after a month in a much lesser context, okay? And B, if the pain or the discomfort ceases, then no endodontic treatment is needed. No endodontic treatment is needed. Okay? Next. Now, what about heavy forces? So in heavy forces, you can have these certain scenarios. So let's first talk about letter A, irreversible pulpitis. So for irreversible pulpitis, you can do treatments such as calcium hydroxide treatment or the root canal treatment. Definitely. Okay? For narrowing of canals, you have to assess. This is not your job as an orthodontist. Okay? As a endodontist, so I have the luxury of calling my wife, who is an endodontist, right? And I just tell her, okay, I have a narrowing of canals here. Can you assess the situation, whether this patient needs or not? So usually it's an observation, and they would take series of radiographs from month to month to make sure that nothing bad is happening. Now, heavy forces can also cause internal root resorption, which would be an indication for root canal treatment. Okay? And heavy forces can also cause external apical root resorption, which is very, very likely. And when external apical root resorption happens, we have to assess this situation and check whether there's inflammation root resorption. Sorry, inflammatory root resorption, if there's replacement of the root resorption, and if it's surface root resorption. So this one usually happens when you apply too much orthodontic force. Okay. Now I believe I have shown you at one point this patient that had no more roots. She had like only the cervical third of the roots. Okay, I can show that to you in a short while. I forgot to put it here. And third, heavy forces can also cause ankylosis. In pre-adolescents, this could be a good space maintainer. But for late adolescent, well, what you have to do is restart the procedure to align the teeth aesthetically. Okay? Okay, so just a little bit of looking into the factors for that are affecting root resorption. We have to look at the severity of the trauma. We have to also observe the diameter of the apical foramen and the presence or history of resorption in the patient. Okay, here's the patient I'm talking about. As you can see, it almost looks deceptively normal. And what I'm gonna do here is I'm gonna, okay, left and right, a little bit of bone resorption there on the right side. Pretty much healthy. But what I'm going to do next is I'm going to remove the bone from the image. And now you're seeing these teeth look like pontics, right? And they look like pontics because of the previous ortho treatment. See how bad that external resorption is? And if you observe in the posterior, which for the teeth that did not receive any ortho, they're pretty good, but for the anterior teeth, no more root. Okay, now for this patient, her bite was actually functionally incorrect. And she needed ortho treatment to fix the coronal part, but there's no root part, so I can't do anything. Okay? Okay, so if ever you have loss of vitality, so say for example this one, this is an anterior retraction case, and because of the poor control of the whole tooth and the application of the forces over here, what happened was the root came out of the bone. And in scenarios like this, because the blood supply is in the bone and the root is already out of the bone, what could have happened here is you can have loss of vitality. So usually the reason is because of uncontrolled orthodontic forces. Okay, uncontrolled orthodontic forces in a sense that you applied the wrong line of action. Next is heavy forces. Heavy forces. Or the force generation. It could also be large increments of change. So you see the teeth usually respond normally 1 millimeter per month. Okay, 1 millimeter per month at an average. So it could be a little bit slightly more, slightly less. Now, if it moves like say 2-3 millimeters more in 1 month, I mean, that's really bad. So you can cause loss of vitality. And the reason why is because you could have severed the blood vessels. Okay? Okay, so FAQs for endodontic context. So can teeth with previous RCTB move as readily as vital teeth? Yes. But do review the quality of root canal treatment that happened. Okay? Now, when you treat your patient, let's say it was symptomatic, right? And then there is reversible pulpitis, and then you did an endo treatment. When should you reactivate? Okay, you should reactivate upon the first sign of healing. So usually this is around 3 months. Okay, but if it happens like within 1 or 2 months period, then you can already start. How do I know within 1 or 2 months? You can take a radiograph. So when you, so for my wife, what she does, say for example, there's a periapical lesion or radiopacity. What she does is she observes this radiopacity and measures it, and then when she observes that there's a shrinkage of that radiopacity, radiolucency, that's when she would tell me, okay, you can go ahead and move it. Okay. So it doesn't have to be like completely healed in that apical area. As long as there's a first sign of healing, then you can do it. Is the amount of root resorption on vital teeth similar to endodontically treated teeth? Yes. Okay, because this is not something that is internal, this is something that is external of nature. And how does orthodontic tooth movement affect healing? Well, it actually improves because if you're doing it correctly, you can actually produce bone around that area. And when you put it in the correct position, you increase the quality of the bone. Who are at risk? Well, anybody. Okay, and what is the prognosis? Well, as long as the restoration or the root canal treatment is perfect and there's no air space in there, then your prognosis is good. But it doesn't stop there. The restoration of that endodontic or that cavity that was there is key to the prognosis of the longevity of the teeth, of the tooth. Okay, so we do have to review. Say for example, you're going to place a crown after root canal treatment. You have to make sure that that crown has no leakage whatsoever. So it has to be perfect, absolutely perfect. Okay. So let's conclude. So orthodontic benefits not only the periodontal health in periodontitis caused malocclusion, but it also helps in improving the prognosis of the condition. Okay, so we are actually the hope of periodontal patients, not periodontists. Periodontists just fix it, but in terms of the stability, they depend on us. Okay? A cautious sequence of planning and execution should be taken in consideration when treating orthodontic patients with compromised teeth needed for endodontic treatment. This one will come in terms of your diagnosis. So there must be a thorough diagnosis, and I believe we have trained you guys to be very thorough in your diagnosis from the picture to the x-rays and clinically. A routine checkup before applying the correct amount of force should be done to avoid any undesired problems. So here is there's an important time that you have to sit down and observe all the teeth. If the type of practice that you're working for does it in a business way, where they are just doing adjustments and you have to finish it within 15 minutes, there is no way that you could check the teeth or the status of the teeth. Okay, so if you're doing cleaning, because the system in those business type of practices is that you have to treat that patient for 15 minutes because the next one is already there. And within this 15 minutes, you should have done cleaning and you should have done your change wire, change elastics. Imagine how fast that is. I mean, you can't even make crucial decisions. I mean, I have to make decisions for like about 15 minutes, and I'm just making a decision. That's not me being slow. That's actually me being fast. So I usually take about an hour, and I do it thoroughly. Okay, so we have to look out for these scenarios if ever they would happen, and we have to protect the patient at all costs. Remember, this is what we're leaning on: the vitality of the teeth and also the health of the periodontium. If they're not good, then the new positions of these teeth are also not going to be good. Okay, at the same time, if the position of the teeth are not going to be good, then these are also not going to be good. Okay, any question?